Welcome to the Pharmacology series, an educational journey through key pharmacological principles. In our last episode, we explored pharmacodynamics, examining how drugs exert their effects on the body. Today, we'll dive into pharmacokinetics, a crucial topic in pharmacology that looks at how the body affects the drug's concentration over time, influencing its onset, intensity, and duration of action. For those preparing for exams like the PSI equivalents, GPhC, NAPLEX, and PEBC, or for pharmacy and medical students, this video provides insights to solidify your knowledge. Medical professionals can also gain a deeper understanding of how drugs behave in the body. And, if you'd like to test your understanding, check out the MCQ quiz link in the description with 10 multiple-choice questions. By the end of the lecture, you will be able to do the following. Understand the importance of pharmacokinetics in predicting drug behavior and ensuring safe, effective dosing. Define ADME, absorption, distribution, metabolism, and elimination, and how each stage influences drug action in the body. Explore factors impacting drug absorption, including routes of administration and drug properties. Influences drug action in the body. Discuss drug distribution and how factors like body composition and protein binding affect where drugs accumulate in the body. Examine the process of metabolism, particularly the role of liver enzymes in transforming drugs for elimination. Recognize the significance of elimination in determining drug duration and required adjustments for renal function. Explain dosage regimens, focusing on concepts like half-life, bioavailability, and dose adjustments in special conditions. As a way of introduction to this lecture, pharmacokinetics is vital for understanding how drugs move through the body and how drug concentrations change over time in different bodily compartments. These dynamics directly impact a drug's efficacy and safety. For instance, WHO estimates that about 10% of adverse drug reactions are due to improper dosing, emphasizing the importance of pharmacokinetics in safe medical practices. ADME. ADME in pharmacokinetics stands for absorption, distribution, metabolism, and elimination, four critical stages that determine a drug's journey and efficacy within the body. Absorption reflects how a drug enters systemic circulation, with bioavailability often ranging from 0% to 100% depending on route, for example, oral versus intravenous. Distribution describes the reversible transfer of drugs to tissues, influenced by factors like blood flow and tissue permeability, typically quantified by the volume of distribution, VD. Metabolism, primarily occurring in the liver via enzymes such as cytochrome P450, transforms drugs for easier elimination. Finally, elimination removes drugs through processes like renal excretion and enterohepatic circulation. 88. Let's look at absorption. Absorption in pharmacokinetics refers to the process by which a drug moves from its site of administration into the bloodstream. This step is critical for achieving therapeutic drug concentrations and is influenced by factors such as the drug's formulation, route of administration, and chemical properties. Drugs taken orally, for example, must pass through the gastrointestinal tract before entering circulation, making their absorption dependent on gastric pH and intestinal motility. Routes of administration. Routes of administration significantly affect drug absorption and bioavailability. Oral administration has slower absorption due to the digestive tract and first-pass metabolism, with bioavailability ranging from 20 to 40%. Intravenous administration delivers 100% bioavailability, while subcutaneous and intramuscular routes have bioavailability between 75 and 100%, influenced by blood flow. Topical and transdermal routes depend on skin permeability, with absorption efficiency impacting the drug's plasma concentration and therapeutic effectiveness. Let's look at factors that affect absorption. These factors include lipid solubility, molecular size, and ionization state. Lipid-soluble drugs, like diazepam, can easily cross cell membranes and are absorbed more rapidly, while water-soluble drugs may require active transport. The pH of the environment also affects absorption. Weak acids like aspirin are better absorbed in acidic gastric environments, while weak bases like morphine favor basic environments. Let's look at the next stage in the ADME process, which is distribution. Distribution in pharmacokinetics refers to the process by which a drug disperses from the bloodstream into various tissues and fluids within the body. This process is governed by factors such as blood flow, tissue permeability, and the binding of the drug to plasma proteins or tissue components. For example, lipid-soluble drugs like diazepam tend to accumulate in fatty tissues, whereas water-soluble drugs like gentamicin remain primarily in the extracellular fluid. Side. This diagram illustrates the pharmacokinetic process of drug distribution, showing pathways of absorption, for example, oral, inhalation, injection, distribution via plasma and tissues. From the diagram you can see major organs and tissues where a drug can distribute into. The free drug interacts with plasma proteins, receptors, and various tissues, undergoing metabolism, enterohepatic recycling, and excretion through multiple routes. Factors that affect distribution. Factors affecting distribution include body composition, age, disease states, and the drug's physicochemical properties. For example, in patients with liver disease, reduced protein synthesis decreases plasma protein binding, which can elevate free drug levels and risk toxicity. Likewise, lipophilic drugs may demonstrate greater distribution in individuals with higher adipose tissue levels, such as obese patients. Volume of distribution, VD, explanation. The volume of distribution, VD, in pharmacokinetics is a theoretical parameter that relates the total amount of drug in the body to its concentration in the plasma, calculated using the equation, VD equals amount of drug divided by plasma concentration is shown below. This measurement, often denoted as apparent volume of distribution in liters and adjusted per kilogram of body weight, VD per kg, to account for body size variations. Drugs restricted to plasma, such as those binding extensively to plasma proteins, for example warfarin, have a low volume of distribution close to the plasma volume, around 4% of body weight. Factors influencing volume of distribution. Volume of distribution varies based on the drug's binding properties. For example, drugs like quinacrine, which avidly bind to peripheral tissues, display an extraordinarily high volume of distribution of up to 50,000 liters due to low plasma concentration despite high tissue binding. Conditions like liver or kidney disease can alter volume of distribution by affecting plasma protein levels. A practical example is digoxin, with a VD influenced by body composition and tissue binding, often used to treat heart failure. Clinical relevance of volume of distribution. Volume of distribution, or V, describes the extent of a drug's distribution throughout body tissues relative to the blood plasma, significantly influencing the required loading dose, LD, to achieve a target steady-state concentration. The loading dose can be calculated by multiplying the target concentration by the volume of distribution, where target concentration is the desired drug level, and volume of distribution is the extent of drug distribution in the body. Drugs with high volume of distribution like digoxin, where V is almost equal to 500 L and is 70 kg adult, distribute widely into tissues, necessitating larger loading doses. In contrast, drugs with low V, like gentamicin, V is almost equal to 18 L and is 70 kg adult, are more confined to extracellular fluid, requiring smaller loading doses to reach therapeutic levels. Let's look at protein binding. Protein binding affects how drugs are distributed in the body. Drugs bind to plasma proteins, primarily albumin, forming complexes too large to cross cell membranes, thus limiting their movement into tissues. For example, basic drugs like propranolol primarily bind to alpha-1 glycoprotein, while other drugs, like phenytoin, are highly bound to albumin, 95%. This binding restricts the drug's action until displacement occurs, which releases the drug, increasing the free drug concentration and possibly intensifying the pharmacologic response. Certain hormones, such as prednisone, bind to specific proteins like transcortin, leading to dose-dependent pharmacokinetics. Transcortin has a high binding affinity but low capacity, creating a nonlinear binding effect, while albumin provides a high-capacity, low-affinity binding alternative. Metabolism. Metabolism, a key phase in pharmacokinetics, refers to the body's chemical alteration of drugs, primarily in the liver, to facilitate excretion. It transforms lipophilic, fat-soluble, drugs into more hygrophilic, water-soluble, metabolites, ensuring easy elimination. This process involves two phases: Phase 1 reactions, mainly oxidation, reduction, and hydrolysis, and Phase 2, where conjugation reactions like glucuronidation make the drug more water-soluble. Metabolism is largely driven by hepatic enzymes, especially cytochrome P450 enzymes, CYP450, which metabolize around 75% of drugs. For instance, CYP3A4, the most abundant enzyme, metabolizes drugs like simvastatin and midazolam. CYP2D6, meanwhile, is highly polymorphic, leading to varied responses to drugs like codeine and metoprolol based on genetic differences. The diagram below shows distribution of different types of cytochrome P450 enzymes. Several factors influence drug metabolism, including age, genetics, diet, sex, disease state, and drug interactions. Genetics and drug interactions are the major factors as shown in the diagram below. Patients with liver cirrhosis exhibit reduced hepatic enzyme activity, affecting drug clearance rates, as seen with drugs like warfarin. Genetic polymorphisms also play a role. Individuals with CYP2D6 deficiency metabolize codeine poorly, impacting its efficacy. Let's briefly discuss what is first-order kinetics before we look at elimination. In pharmacokinetics, first-order kinetics describes the rate of drug elimination, where a constant fraction of the drug is metabolized per unit time. This rate is directly proportional to the drug concentration in the plasma. For example, if the half-life of a drug is 4 hours, 50% of the drug will be cleared every 4 hours, regardless of the dose. First-order kinetics applies until the enzymes responsible for metabolism become saturated, after which zero-order kinetics may occur. Plotting drug concentration versus time results in a curve that decreases exponentially as shown in the diagram below. The graph shows a steep decline initially, gradually flattening as time progresses. The rate of elimination is proportional to the drug's concentration, meaning a constant fraction is eliminated per unit time. Let's look at zero kinetics. Zero-order kinetics describes a drug elimination process where the rate of elimination is constant and does not depend on the drug's plasma concentration. This is unlike first-order kinetics, where elimination rates vary proportionally with concentration levels. In zero-order kinetics, when plotting drug concentration against time, the graph shows a straight, downward-sloping line, indicating a constant rate of drug elimination. The slope is uniform, representing the fixed amount of drug eliminated per unit of time. This contrasts with the exponential decay seen in first-order kinetics. In zero-order kinetics, a fixed amount of drug, such as 10 mg per hour, is removed from the body, regardless of concentration. Most drugs follow first-order kinetics except a few. So, zero-order pattern is observed in drugs like ethanol, aspirin, and phenytoin, especially at high or saturating doses. Due to saturation of enzymatic pathways, the body cannot increase elimination as concentration rises, leading to potential accumulation and toxicity. Elimination. Elimination is the process by which a drug is removed from the body through metabolism and excretion, determining its duration of action and overall clearance. We have already looked at metabolism in the previous S. So let's define what is excretion. Excretion, in pharmacokinetics, refers to the removal of drugs and their metabolites from the body, primarily through renal, kidney, and hepatic processes. It plays a key role in determining a drug's duration of action, as it finalizes the elimination process that began with metabolism. The kidneys filter roughly 180 liters of blood daily, excreting drugs via urine, depending on factors like lipid solubility and ionization. Factors influencing excretion include age, renal function, and drug properties such as molecular size and protein binding. For example, reduced renal function in elderly patients can lead to decreased drug clearance, increasing the risk of toxicity. Drugs like gentamicin and digoxin are renally excreted, requiring dose adjustments in patients with compromised kidney function to avoid accumulation. Additionally, ionized, water-soluble drugs, for example, penicillin, are typically excreted more efficiently than lipid-soluble compounds. This diagram below shows drug excretion through the nephron, highlighting glomerular filtration, tubular reabsorption, and secretion. Drugs initially enter the nephron at the glomerulus, where small molecules are filtered. Reabsorption and secretion occur in the proximal tubule, loop of Henle, distal tubule, and collecting duct. Aldosterone influences sodium and potassium balance in the distal tubule and collecting duct, ultimately impacting drug concentration and excretion in urine. Let's look at the pharmacokinetic parameter called clearance. Mathematically, clearance, Cl, relates the rate of elimination to the plasma concentration is given in the formulae below. For a drug eliminated with first-order kinetics, clearance is a constant, that is, the ratio of rate of elimination to plasma concentration is the same over a broad range of plasma concentration. Clearance is sometimes expressed as clearance per kg of body weight. The magnitudes of clearance for different drugs range from a small percentage of the blood flow to a maximum of the total blood flow to the organs of elimination. Clearance depends on the drug, blood flow, and the condition of the organs of elimination in the patient. Half-life. Half-life or T-half in pharmacokinetics refers to the time required for the concentration of a drug in the bloodstream to decrease by half. For drugs following first-order kinetics, this is a constant and is calculated from two primary factors, volume of distribution, Vd, and clearance, Cl, using the equation below. Where T-half is the half-life of the drug, Vd is the volume of distribution, Cl is the clearance. This parameter indicates how long a drug stays active in the body, influencing both dosing frequency and therapeutic effectiveness. In clinical settings, half-life helps predict drug accumulation during repeated dosing and clearance after stopping administration. For example, drugs reach approximately 87 to 90% of steady-state levels after 3 to 4 half-lives, which is generally sufficient to maintain therapeutic effects. Effective drug concentration. The effective drug concentration is the level required to achieve a therapeutic effect, and this level falls within the therapeutic window. For example, monitoring digoxin levels is essential, as therapeutic and toxic levels are close. The therapeutic window is the range between the minimum therapeutic concentration, MTC, and minimum toxic concentration, MTC, of a drug, providing a safe, effective plasma concentration. For drugs given intermittently, the minimum effective concentration, MEC, defines the desired trough level, while the minimum toxic concentration sets the upper limit for peak plasma levels. For instance, theophylin's therapeutic range is 8 to 20 mg per liter but can become toxic at concentrations over 15 to 20 mg per liter. Drugs like theophylline require close monitoring to maintain levels within the therapeutic window. The window for a particular patient could be narrower, such as 8 to 16 mg per liter, to avoid toxicity. When the therapeutic and toxic levels vary widely among patients, drugs need individual titration, like digoxin, where patient-specific factors impact dosing and plasma levels significantly. Bioavailability and routes of administration. Bioavailability, F, is the fraction of an administered dose that reaches the bloodstream in its active form. For intravenous drugs, bioavailability is 100%. But oral drugs often have lower bioavailability due to absorption barriers and metabolism. Metronidazole's bioavailability varies significantly by administration route. Orally, it has high bioavailability at around 90%, allowing effective systemic absorption. When administered intravenously, bioavailability reaches 100% as it directly enters the bloodstream. In contrast, topical metronidazole powder has only 1% bioavailability, indicating minimal systemic absorption, as it is designed for localized action on the skin. Let's look at area under the curve, AUC. The area under the curve, AUC, represents the total drug exposure over time, calculated by plotting drug concentration in the blood versus time. AUC reflects the extent of drug absorption and is directly related to bioavailability, the fraction of an administered dose reaching systemic circulation. Higher AUC values generally indicate greater bioavailability, meaning more of the drug is absorbed and available for therapeutic effect. Comparing AUCs of different formulations or routes helps assess relative bioavailability, essential for evaluating the effectiveness of drug delivery methods. 88. Dosage regimens. A dosage regimen in pharmacokinetics is designed to maintain therapeutic drug levels in the body, typically involving a loading dose and a maintenance dose. The graph below shows the change in drug concentration as time elapses when a loading dose is given and when loading dose is not given. The loading dose quickly raises plasma concentration to therapeutic levels, essential for drugs with long half-lives, like digoxin, to achieve rapid therapeutic effects. 8. Maintenance dose. A maintenance dose is the amount of drug administered at regular intervals to keep the plasma concentration within the therapeutic range after reaching steady-state levels. Maintenance dose is calculated by multiplying the target plasma concentration, C-target, by the drug's clearance rate, Cl, and the dosing interval duration. 8. The maintenance dose is crucial for keeping drug levels within the therapeutic range over time, balancing drug elimination to achieve steady-state concentration. Proper dosing ensures efficacy while minimizing toxicity, making it essential for chronic conditions or long-term therapies where consistent blood levels of the drug are required for optimal treatment outcomes. We want to look at adjusting doses in disease conditions. When adjusting doses in disease conditions, particularly renal impairment, pharmacokinetics plays a critical role in ensuring drug safety and efficacy. Kidney function directly influences drug clearance, primarily for renally excreted drugs. One method to estimate renal function is the Cockcroft-Gault formula, which calculates creatinine clearance, CrCl, using patient age, weight, gender, and serum creatinine. The Cockcroft-Gault formula is an indicator of kidney function and it is used to adjust drug dosages, especially in renal impairment. The formula is as given below, where CrCl represents creatinine clearance measured in milliliters per minute, and age refers to the patient's age in years, while weight is the patient's body weight in kilograms. Serum creatinine represents the creatinine concentration in the blood, measured in milligrams per deciliter. The factor 0.85 is used to adjust the calculation for females, accounting for generally lower muscle mass compared to males. Key pharmacokinetic parameters, such as clearance and half-life, are altered in renal dysfunction, making dose adjustment crucial. For example, antibiotics like gentamicin require extended dosing intervals to avoid toxicity in patients with impaired renal function. Similarly, metformin, which is excreted unchanged by the kidneys, needs careful dose reduction if creatinine clearance falls below 60 mL per minute to avoid lactic acidosis. Recap. In this lecture, we explored how drugs move through the body and the impact on efficacy and safety, emphasizing WHO's concern over adverse effects from improper dosing. We discussed ADME, absorption, distribution, metabolism, and elimination as key stages in drug movement. Absorption depends on the route and formulation, with oral drugs facing absorption barriers, while intravenous drugs achieve full bioavailability. Distribution factors include blood flow and tissue affinity, affecting drug accumulation in tissues. Metabolism, mainly in the liver, uses enzymes like CYP450 to transform drugs for excretion. Elimination completes this process, primarily through renal pathways. Understanding pharmacokinetics helps in dose adjustments for patient-specific needs, especially in disease conditions like renal impairment. Conclusion. Understanding pharmacokinetics is fundamental to effective drug therapy. It allows us to tailor doses, monitor therapeutic windows, and ultimately improve patient safety and outcomes. Future plans and further reading. Next in our series, we'll explore drug metabolism, examining how the liver processes drugs and the effects on dosing and efficacy. Be sure to watch the next video in our series, and for those interested in a deeper dive, I recommend resources like Katsung and Trevor Basic and Clinical Pharmacology, Rang and Dale's Pharmacology or BNF Guidelines. If you found this video helpful, please give it a thumbs up, subscribe, and leave any questions in the comments below. Learning pharmacology is a continuous journey, and we're here to support you. Thanks for watching, and we look forward to seeing you in our next video.